This isn't going on and staying
Yep,
on.
you're good.
But it's not going on. Oh,
You're good.
all right. It's all good.
You're good.
Okay. Good morning, everyone. Can you hear me okay? All right. Welcome to the Prostate Cafe. This is our monthly meeting, typically on the last Friday of the month. Okay, but thank you for coming. As it says behind me, you bring the questions and we'll bring the breakfast. And Johnson & Johnson has sponsored our breakfast this morning. And I'll just talk a few minutes about their products because we use a lot of them. One of which is, it's called Erlita. It's also known as apalutamide. And it's a second generation or a next generation agent. It works along the hormonal axis. Ordinarily, we use drugs that suppress a molecule that's created by the hypothalamic pituitary axis of the brain, and which goes down and works at the level of the testicles to ultimately suppress the production of testosterone. The thinking being is that prostate cancer, as many of you know, is fed by the male hormone testosterone, so that by shutting down its production, you're depriving those prostate cancer cells of the food that it's necessary. And that works very effectively. It's been around for a long time. Those drugs too have advanced over time. They're referred to as LH-RH agonists. Sometimes we just call them GnRH drugs. That's how they work. They take away testosterone. On another level, however, is the product that I mentioned, apalutamide, known as Erlita, more commonly. And what it does is it does not take away testosterone, but rather does not allow the testosterone to touch the cancer receptor. So it's at that level. So it's very precise in its action. And we use it a lot. And one of the advantages of it is that in contrast to taking away testosterone, it allows testosterone to do its own thing. So it really doesn't interfere with the production of testosterone. It just inhibits its interaction with prostate cancer at the cellular level. And that's one agent. There's another group of drugs they're called PARP inhibitors. And this is just another group of drugs which have also fairly profound effects against prostate cancer, but those are used in patients who have mutations, and most specifically in patients who have BRCA mutations. And you may have heard of this, but it's often a familial or genetic predisposition to prostate cancer. Some people just create it also as a mutation, having no pre-existing genetic abnormalities. So anyhow, really interesting drugs. It's moving along. You know, we like these next generation agents. We like immunotherapies and the PARP inhibitors, and you know, it's hopefully will one day supplant entirely chemotherapy. Anyhow, are there any questions to begin with at this time? Okay. Yes, sir.
I'd like to know more your explanation of a TERP and how you would consider it versus other alternatives. As far as what exams would you do before deciding to have a TERP? Does cancer play a role in the decision-making process, and would you consider other treatments besides just jumping off into a TERP?
So this gentleman's asking about the role of a TERP, which stands for transurethral resection of the prostate. And it is, as it says, it bores out the prostate. The urethra lives right down the middle of the prostate, and sometimes the tissue collapses upon the urethra, and more importantly, upon a sphincter, which is just above the prostate urethra, and causes all kinds of urinary problems. One of which is we call bladder outlet obstruction. It's also known as LUTS, L-U-T-S. You may hear that, and lower urinary tract symptoms. What a TERP does is it basically unencumbers the prostate urethra and that bladder sphincter. But TERPs are, we think, kind of old school now, although they're still performed and there's nothing wrong with them. But certainly in the face of cancer, you have to be careful of a TERP because we have documented that TERPs spread prostate cancer. Okay, so that if you go in there and you're boring out the prostate where there's cancer in it, and especially in the center of it, then you could potentially be dispersing the cancer throughout the body because it's a fairly bloody operation. Okay, but its end goal is to improve your urination. I mean, that's the end goal of a TERP, but have to be careful if you have active prostate cancer. Now, sometimes, so we'll look at the prostate. And that's the shape of the prostate. This is the top, that's the bottom. We call the top the base, we call the bottom the apex. And it's segued into a right and left side, and then the prostate urethra goes right down the center. So as I was saying, if there's a cancer, and let's just say there's a cancer here or a cancer here, well, they may not influence or affect the central prostate urethra that much, okay? And because they're kind of growing on the side, but what happens is two things. Number one, they're increasing the volume of the prostate so that tissue of the prostate is just getting kind of taken up. The space is getting taken up, so it starts pushing towards the center, or cancer can grow right into the prostate. Above the prostate are these appendages that we call seminal vesicles. And they're basically the reservoirs for the seminal fluid, the ejaculate, as you know. And the prostate's a sexual organ, it has a lot to do with orgasm. It's actually the G-spot in men. It makes most of the seminal fluid, which you may know as the ejaculate, and then stores it above here in these appendages called the seminal vesicles. It also carries the nerves go to the penis, so it's really a very sexual organ. But right here is the bladder, and much bigger than that, actually. It's probably 3-4 times the size of the prostate. But right here, the bladder comes together with these seminal vesicles, which comes together with the prostate urethra. And a lot of times, what happens with cancers is they grow into these seminal vesicles, and then they push this way. So they're pushing that way into that urethra, and they're crushing it, so to speak, or more importantly, and most commonly, they're influencing this big bladder muscle. And this is a very big bladder muscle at the very bottom of the bladder. And we call that big bladder muscle the internal sphincter. And the internal sphincter muscle is your control center. When you want to go, it opens. This big muscle here opens. When you want to close and stop your urinary flow, you close it. And when you gotta go, it's more often than not the prostate urethra that's being pushed on as much as this big sphincter muscle, because it is a muscle. And when a muscle gets pushed on, it gets annoyed. And that annoyance basically gives us what we call urgency, urinary urgency. You gotta go, you really gotta go. And it's often because of this. Now, I just drew you a picture of a cancer, okay? And on the other hand, prostate can just grow in size. So we call that benign prostatic hypertrophy. And as men start at around age 30, their prostate glands can get larger. And every decade that goes by, the prostate gets larger and larger. And so what it tends to do is push again into the prostate urethra. But again, in my experience, it's not so much the prostate urethra as it is this big muscular valve. And there's actually a component of the prostate that we often call a benign median lobe. And what it basically means is that the prostate itself, it's growing, but there's another part of the prostate growing right into that muscle. And it really annoys the heck out of the bladder. So in both of these situations, you might want to, take the weight off of that big sphincter and take away some of the mass of the prostate, either by benign or malignant properties. But as I mentioned, if you just think about this picture, now roto-rooter is another name for TERP. And you go in and you roto-rooter it out. But in the process of roto-rootering it, you may be spreading that cancer throughout the body. That's a problem. What I suggest is if a roto-rooter, also called a TERP, is to be performed, perhaps you do have prostate cancer, but perhaps it's along the edge. And that needs to be defined, because if it's along the edge of the gland, which is where prostate cancers typically begin, we call that the peripheral zone, the edges, the peripheries. Well, then you're not really roto-rootering the cancer itself. Okay. But I got to tell you, I evaluate obviously a lot of men with prostate cancer who've had TERPs. And what I often see is a big roto-rooter job like this, where this tissue has just been taken away. And it works. Guys will say, wow, I can pee like when I was 17 years of age. However, the other thing they may say is, and I got a lot of leakage, because what happened is this big sphincter was removed, and that's an important sphincter, as I've mentioned. That's a problem. So more often than not, we don't go the direction of a TERP. So we like to do other things, and there are many other things. One is, it's called a green light laser vaporization, and it's basically going into the same area and then vaporizing the tissue that is currently causing a urinary obstruction. And that's one method. There's also Olympus button vaporization. I published on that. There's a poster back there where I published on that procedure when doing it in conjunction with a radiation regimen. The other types are, for example, there's one called holmium laser button removal or enucleation. And I just spoke to a guy a couple days ago. He had a lot of tissue removed from his prostate. So there are different avenues you can go. There's other things being done, including water, heating water up and removing tissue. But in the ideal world, you really don't want to be talking about removing that internal sphincter, because then what you're doing is you're relying after that, this sphincter is gone. There's another group of sphincters down here, but they're really small. And if you got this one removed by any of the procedures I just mentioned, then you have to rely on these little sphincters down low for the rest of your life. And they may not be up for the task. So that's kind of the long and the short of it. Sometimes you just have to do it. You have to do a TERP because a patient's obstructing. Sometimes there is cancer in the way. So what I generally recommend in that situation is to use hormonal agents. And what the hormonal agents do is they basically shut down the cancer for a while. They make it less active. And so they're kind of, even if you did spread some, they're damaged goods. They can't go somewhere and, take another home somewhere else in your body. So that's an alternative that I don't often recommend, but if it has to be done that way, then it has to be done that way, because maybe, a guy just can't pee and he's got to wear a urinary catheter because he can't. So that's one of the rare exceptions when I would recommend that procedure. So that's pretty much, does that answer your question?
But cancer should be eliminated. before you even start the process, you need to identify whether you got cancer or not, like getting an MRI or something before.
Yeah. So
Or even the discussion.
yeah, so he's asking, shouldn't this be evaluated up front? Absolutely. So, as I say, maybe the cancers are over here. You don't even have to worry about it when doing any of those procedures, vaporization or otherwise, or the TERP. And, an MRI is a really good tool to let you know exactly where the prostate cancer is. Probably the best of all. And, there's ultrasounds too, but the MRI is probably the very best in defining where cancers are. You're welcome. Okay, any other questions at this point? Yes, sir.
So an MRI is better at determining cancer than, say, a biopsy, and getting with the biopsy, does that disturb cancer cells in the prostate if there is cancer present?
Right, so he's asking, I believe, timing, MRI, biopsies. If you have an MRI, do you not need a biopsy? Not really. What the MRI does is it lets you know if you need a biopsy. So in the past, MRIs weren't so good in defining whether or not a patient had prostate cancer. And let's just say 10, 12 years ago, a radiologist looking at an MRI of the prostate, he might say, well, there's probably a cancer, okay? And that's as good as he can get. And then they realized the reason for that was that the prostate moves around a lot. So we know with MRIs, for example, their best uh, abilities are in bones. Why is that? Well, the bones don't move, okay, except for the ribs. But generally speaking, bones, whether it's your hips or your knees, wherever it is, bones don't move. So when you're imaging, nothing's moving, and the MRI gives a wonderful picture of it. However, they came to realize, but the prostate moves a lot, and it's influenced by all kinds of things around it. The bladder on top of it and falls in front of it is pulsating. The rectum behind it is pulsating. The diaphragm beneath it is pulsating. Small bowel, large bowel, it's moving a lot. Okay. And they realized that in order to better image the prostate, they had to increase the strength of their magnets. And that's what they've done. And many radiology centers now, good ones, will have a stronger magnet. And with the ideal right now being, it's called a 3.0 Tesla magnet. Okay. And what it does, it just does a fast frame review by MRI to enable them to capture the images better than in the old days, so that the radiologists can now look at it and say, oh yeah, there's a cancer. They've gotten so good now with another way of looking at it, and they call that multi-parametric MRI. They say there's a cancer, and we predict that cancer is going to behave this way: benign or less aggressive or very aggressive. And that's under the catchment of a term we call PIRADS. So PIRADS in the radiologist world goes from 1 to 5. 5 being their prediction or forecast of the most aggressive cancer, 1 being the least aggressive. So if, again, when they give their reads, and you'll always see it if any of you've had radiology reports, it's going to say, yes, there's a mass here or there if they find one. And then they're going to say, and it's a PIRADS 1, 2, 3, 4, 5, with 5 being the most aggressive. That's information, because it's information you didn't have, but that might say, okay, it is a PIRADS 4 or PIRADS 5. We're forecasting it to be aggressive. And they're usually right. They've gotten really good. A lot of it's done by AI now. Okay. And if it is a 4 or 5, maybe even a 3 in large, then the role for doing a biopsy is made. Now, sometimes, you have an MRI and it shows a 1 or a 2, and then a decision, well, is it necessary to do a biopsy? Are there other factors at play? So typically, an MRI is done in advance of a prostate biopsy to determine if it should be done, and then where should my biopsies go? Are they going to be going directly into a lesion that the MRI happened to show over here or over here? Because there's something called fusion technologies now, where you input the images from that MRI into a hub where it's fused with the biopsy program. And so there's no guesswork. So you know where the tumors, wherever they may be in the prostate, are located. Now, with respect to the other question he had is, can prostate biopsies spread cancer? Because we know biopsies can. And well, let me give you another diagram here. So that was a front view of the prostate. A side view would be something like this. And it just so happens that the rectum is directly behind the prostate, like that. And this is actually the anus right here. And again, here's the prostate, but most prostate biopsies go through the rectum. Let me get another pen here. Put this one away. Oops, excuse me. So most prostate biopsies, a probe is put in the rectum, and through the actual probe, tiny needles jettison out into the tissue around the prostate, and that's referred to as transrectal ultrasound guided biopsies. By far the most common way that prostate biopsies are performed in the United States and abroad. I'd say 99%, maybe greater. Okay, and that's the way it's done. There are some problems that I have with that anyhow. I used to do them that way. One of which is if the prostate's really large, there might be some tumors here, or your MRI may say, oh, there's areas in the front of the prostate gland that need to be biopsied. And it may be that these needles, which are only so long, can't even get to those. So that's one of the problems. Excuse me. The other problem tends to be there's a lot of nerves in the rectal wall, and you can't avoid them with a transrectal prostate biopsy. There are nerves in the prostate too, and there's plenty of them. It just so happens, though, if you engage the rectal nerves, it's far more painful. They're just bigger nerves, and the aftermath is that, oh, it smarts. You may have had anesthesia during the procedure, and hope you would if you had transrectal prostate biopsies, but it's going to hurt even afterwards. It's going to throb, and it'll be kind of a sharp pain because of the big nature of those nerves. The other really big deal associated with going through the rectum to do a biopsy is that the rectal wall has a lot of bacteria. And no matter how well you try to purge and clean your rectum, you just can't make it 100%. It never will be. You could do all the Fleet's enemas and bowel preps in the world. There's still going to be bacteria 100% of the time. And so 100% of the time you are introducing bacteria from here to there because you're going through that rectal wall. Now, does everyone get infected? Absolutely not. If we were all in a room with COVID people, we all wouldn't get, infected, but maybe 15 to 20% would. And that's pretty much the percentage when patients undergo prostate biopsies. 15 to 20% get infected. The problem with that is 5% end up in the ICU. Those 15% do typically end up in an urgent care or ER, but it's more commonly because of a urinary tract infection, because it introduced the bacteria into the prostate, and then that got into the bladder, which again, in this picture, the bladder is here above the prostate, and then you got the prostate urethra joining the bladder here. So what happens is the bacteria can get into the prostate, get into the urethra, and then eventually the urinary system. And that's how it works. Another problem, which lends itself to his question, is there's also very big vessels in the rectal wall, just as there's nerves, big ones. And those vessels also can be invaded by your needle. They typically are. And that makes for a bloodier procedure. Again, there's plenty of vessels in the prostate too, but they're smaller. So patients who undergo transrectal prostate biopsies will have more blood, but the more important part of it is that they're big enough vessels that they communicate broadly with your body's circulation, liver, lungs, heart, brain, bones. And so there has been data suggesting that transrectal prostate biopsies could actually spread prostate cancer. And there's plenty of data. I mean, it's not disputable anymore. It's a small percentage though, and I wouldn't worry myself about it, if that's the direction you've already had or a direction you're going to go. But it's real. It's not zero. For all those reasons, what I prefer, and again, this is the rectum. There happens to be an area right around here, and it's called the perineum. And the perineum sits between the anus and the scrotal sac. Here's the penis, and it's an area of skin that, if you were to put your finger between your anus and your scrotum, you're touching the prostate. And of course, this is a magnification. The prostate's smaller, but you can get to anywhere, any location of the prostate, including if it's on the front side of the gland, if it's on the back side of the gland, if it's on the top of the gland. There's just nowhere you can't get to. That's important. Secondarily, this area here, which is skin, can be sterilized. So in contrast to trying to make your rectum sterile, this can be sterilized. So infection rates go down to almost zero. Okay, and that's important. Thirdly, you're not engaging those big nerves, just the smaller nerves in the prostate. And that tends to mean that, you get, I do them, for example, under what we call twilight anesthesia. So you don't know the procedure is being done. But when you wake up, if you have discomfort or pain, it's really minor and it goes away pretty quickly, just because those nerves that were invaded are really tiny in the prostate. And then also, we're no longer going through the big vessels in the rectal wall that can communicate with other parts of your body. It's just tiny vessels in the prostate. And what tends to happen, if that's the only problem, well, then the blood kind of meanders back to the urethra. It goes back into the bladder, and then the blood is just peed back out the urethra to the penis. So there's never been a single report of a patient having undergone what we call transperineal prostate biopsies, to be contrasted with transrectal prostate biopsies. The transperineal, there's not a single report in the medical literature ever showing the dissemination of cancer by that procedure. So, yes, sir.
Real quick, what's the plasma button term? Secondly, after that, could you just explain, I noticed in your book, the differences in IMRT and CyberKnife? Those two questions. And plasma, you could just cover briefly, but the plasma button term, what does that mean?
So he's asking what a plasma button terp is. And what that basically is, it's just another way of vaporizing the tissue of the prostate. Yeah, it's better than the Roto-Rooter by far. Yeah, it's actually, that's the one we call the Olympus button vaporization. And I've done both green light laser vaporization, the Olympus button. They're both fine. They get the job done. I think they get the job done better than a TORP or TERP. Then he asks, what's the difference between IMRT and CyberKnife? Well, CyberKnife is a type of IMRT. Okay, and IMRT is basically a way of developing a beam array with your radiation technologies to zero in on the location of the prostate and prostate tissues and prostate tumors and avoid other areas around it. It wasn't that long ago when radiation was delivered that you didn't have the advantage of all the technologies we have today. And what you would basically do is say, well, I'm going to point the beam, at an area where I know the prostate lives, but it also lives there as the bladder and rectum and all other critical structures. So IMRT was an incredible innovation in radiation to this day, which enables us to avoid consequences, which is damage, rectum, bladder, while being far more precise. CyberKnife is just another form of IMRT where it's done in a longer time frame. So you go for an IMRT treatment, but it's done, let's say, for 15, 20 minutes nonstop. And so you're getting a much higher dose right then and there. And then you repeat that, but it's typically repeated over a shorter period of time. So men who have CyberKnife will also talk about, well, I only had 5 treatments, 10 treatments, things like that. Whereas men who've had IMRT will talk about having treatment for, 8 weeks or 9 weeks. So it's just a way of delivering the radiation in a shorter packaged amount. Now, many, including myself, don't like CyberKnife because we think that, yeah, the technologies are good, but they're not that good, and if you're off a millimeter, again, you're into the rectum and the bladder and you're into critical territories, and that may come home to roost. Maybe not now, but 4 or 5 years from now, that tissue that saw that extra dose, starts to become more and more friable and break down. And that's what I don't like about the CyberKnife. Are there any other questions? Yes, sir.
The difference between, obviously you can remove the prostate versus having seeds implanted. What is the difference from a medical standpoint? Is it a certain type of cancer versus an aggressive cancer versus a middle of the road cancer?
So he's basically asking the difference between radical prostatectomy and prostate brachytherapy. Okay, and in both cases, let's go back to our initial diagram where you have that heart-shaped prostate. We often talk about it being like a small fruit or a walnut, but it's really heart-shaped. And what happens is when you do a radical prostatectomy, you're saying, well, there's tumors. I got to get rid of this cancer. Okay. And you use a special method. It's called Da Vinci robotic radical prostatectomy. And a long time ago, I did that. And what you basically do is you peel it off of the surrounding structures. And in the process, though, you accomplish the removal of the prostate. Now, again, if you just remember the diagram, here's your urethra. Here's the big valve that's going into your bladder. And the bladder is above it and falls in front of it. The problem with that procedure is that you peel it off and then you have to take out these seminal vesicles, which I talked about also as being the reservoirs for the ejaculate. But you have to take out the internal sphincter muscle of the bladder. That's a really big deal. Okay, it's got to go. No one's ever done it differently, or at least to my knowledge, nor is anyone doing it differently. This has to be removed. And again, you've relied on this internal sphincter for most of your life, but after having the prostatectomy, it's removed, and now you have to rely on, so the urethra comes down like this, another group of sphincters below it, but they're really small. And we call those the external sphincters. Internal sphincter, external sphincter. So that most men who've had their prostates removed surgically by radical prostatectomy do have issues with leakage and incontinence. It's a big deal. Okay. And, most men getting prostate cancer aren't 20 or 30, and as we get older, our muscles get weaker. And with every year that goes by, this muscle, if it's the remaining muscle, just gets weaker and weaker. So for those men who only have maybe some dribbling and not a really big deal with leakage, it becomes pretty much incontinence as years go by. We would say florid incontinence, wearing more and more Depends and diapers and things like that. So a long time ago, I didn't like that. Also, I mentioned the prostate's a sexual organ. And so the two major events with radical prostatectomy was incontinence of urine and sexual dysfunction. It's just what it is. So I tried to figure out some other way of doing it. And I was involved with doing something called brachytherapy. And I had a lot to do with the pioneering of that, where you put these tiny little materials directly into the prostate and you boost up the tumors, and then you put in a specific array other seeds, and the objective is to accomplish exactly the same thing as the radical prostatectomy. So the radical prostatectomy removes the prostate tissue, okay, and the prostate cancer. The seeds end up accomplishing the exact same thing, and there are different ways of doing brachytherapy or seed implantations. Sometimes you put them in permanently, sometimes you just put them in temporarily. There's different ways to do it, but the end goal is to eradicate cancer and then the tissues in the prostate. And I would argue at any time that prostate brachytherapy rivals surgery in terms of the eradication of the cancer inside the prostate. And when doing that, you don't have to touch the big internal sphincter muscle. So you retain continence. So, that's obviously a very big deal. Also, you're leaving the prostate intact, so at least men have a go at still having sexual function. And so those are the general things. And of course, when I was doing the prostatectomy, it would take, say, 2.5 hours with a scalpel, and I can do prostate brachytherapy. I did 5 yesterday. They take 15 to 20 minutes without a scalpel and without blood dispersion, so you don't lose blood and cause the same problem I already mentioned about the potential dissemination of cancer from the procedure itself, which again has been very well documented with radical prostatectomy. And also, again, leaving the prostate intact. So those are the reasons, or the two types of therapies which can address prostate cancer inside the gland. Yes, sir.
This Erlita, by the way, that was an excellent summary. I think of certain things. This Erlita, what do you think of Orgovex, the tablet, compared to this? And what do you think of that hormone drug? I'm probably not pronouncing it right. Orgovex.
Yeah, so he's asking about hormonal agents, and he was asking Erlita and a drug called Orgovex and Lupron. So Orgovex and Lupron, they're called LHRH agonists or GnRH agonists. And what both of those do is they shut down a hormone in the brain that goes down and stimulates testicular flourishment of testosterone. So they're a central cutoff, so that if you had a testosterone of, let's say, 500, in no time it's going to be less than 50 or even less than 20. And both Orgovex and Lupron do that. Orgovex is a pill. So some men like to do Orgovex because it is a pill, but you got to do it every day. But it accomplished that suppression of testosterone. Meanwhile, Lupron is an injection, and that's just one of many. We do Lupron here, we do Trelstar here, we do Eligard and even Firmagon, and they're all ways of injecting an agent that accomplishes the same thing as the pill does. Many men like to do that because they get the injection, they don't have to worry about it for 6 months. Okay, and that's that. But that's what we call primary hormonal therapy. Its objective being to take away testosterone. By doing that, starving the cancer. Erlita, however, is different. It's a next generation, or sometimes we call it second generation agent or hormone, which doesn't take the testosterone away. It just doesn't allow what testosterone you have in your body to touch the cancer receptor. So it's just more precise in its action.
What do you recommend? Do you give a reference?
Typically, when we give Erlita, we do it along with primary hormonal therapies. The reason we do that is because there's a lot of data. So I'm obviously a radiation oncologist, and there's a lot of data which suggests that men who get radiation can benefit also by getting simultaneous hormones. Now, the reason for that is this.
I didn't get that. Could you try again?
She'll tell us all the answers.
No, I'm sorry.
Yeah, that's all right. So anyhow, where was I going with that? Yeah, so basically, thank you. Radiation hits the DNA of cancer, okay? And what it does is it splices it. However, cancers are crafty. They they don't always, they try to find a way to repair that DNA and say, sorry, we're going to continue to grow. Well, what hormones do is they don't allow that to happen. So they really impair the ability of the cancer cell to repair. So it appears that when you give them simultaneously, you give the radiation, breaks the DNA strand, and then if it does try to recover, it cannot because the hormones are on board. And that's a primary tenet for why it works and has been identified a long time ago. So we have data, dating back to the 80s, sometimes maybe even a little sooner, showing that hormonal therapies given concomitantly or at the same time of radiation works better than radiation alone. Okay, and we often talk about that as being a sensitizer. It makes the radiation work better. Obviously, a big advantage. The other potential advantage is this, and that is hormones as a group, they stimulate the immune system. So, we often think about chemotherapy, well, it drops your immune system. And, you may have known people who've gotten it and, it can be toxic. Well, hormones, they do stimulate the immune system. Meanwhile, interestingly, radiation also stimulates the immune system. And it appears that when you give them simultaneously, that 1 + 1 might equal a bigger number, like 5 or 6 in terms of killing cancer cells. That's the data, but that's the data primarily when using the primary hormonal therapy, such as Orgovyx, Lupron, Eligard, Trelstar, okay, all of those. Right now, and so far, we don't have that data with the other ones that I talk about, Erlita, for example, the one that just blocks the receptors. It may come out that's every bit as advantageous as the primary hormonal therapy, but we don't have that data right now. So what we try to do is use it when we can to kill prostate cancer cells, but while having the other aspect, the primary hormonal therapies on board, so you can get the 1 + 1 = 4 or 5 or 6. What I like to do is use the one that gives the 1 + 1 = 4 or 5 or 6 sensitizer initially, and then kind of get you off of those, and then use the second line agents, which have less potential side effects, to then target just the cancer receptors if they're around. Now, the other utilization for these drugs like Erlita, and there are others, and they just keep coming out. I mean, now we have Nubequa, and we have Zytiga, and and there's a whole group of those types of agents called next generation agents, but they're very effective, but they seem to be even more effective in cancers which are more advanced. So those cancers are going to lymph nodes, lungs, bones, what have you. And it's just a more thorough takedown of the cancer by using both. So, and in fact, if you try to get the second line or next generation agent, you're going to have a box checked that says your cancer has spread. Okay, otherwise you'll never get it because, well, you can get it, but it'll cost you a lot of money. They're very expensive, tens of thousands of dollars per month. So the criteria has to be met in order for insurances to pay that. And typically it's for more advanced prostate cancer.
What are those common side effects from the hormone?
So he asks about side effects of hormones, and it's taking away testosterone. And for women here, when you take away estrogen, it kind of can turn you upside down. So mood swings can happen. Okay, you can get hot flashes. Perhaps the single most common side effect is hot flashes. Okay, and then of course, because your testosterone's gone, sexual dysfunction. You may be able to get an erection, but you'll have no interest. It just takes it away, and guys have told me you could have, a supermodel put in front of them, he doesn't pay attention. But it's temporary, and it's temporary phenomenon. And probably if you're being recommended to do that, it's probably worth it. There's a good reason for doing it. But those would be the three major ones. Now, you could also have fatigue, and that can happen. My own experience is that short courses of hormones don't really cause a whole lot of side effects. And I usually define that as 6 months or less, but sometimes even a year or less. But I know more and more they're giving these long courses of hormones, minimum of 18 months up to 3 years. They can cause a lot of side effects doing that. And for that reason, I try to get my men off of the primary hormones, the ones that take away all the testosterone, and get them onto the next generation, which are more precise. So they're not having the starvation of testosterone, not only to the cancer, but the rest of their bodies. So it's basically, it's the male menopause is what it is. And very similar to women, and okay. Yes, sir.
How long do you recommend hormonal therapy before you do radiation? A month, 2 months?
So he's asking how long do we want to give the hormonal agents before beginning radiation? And I have looked at this extensively. Again, in the back, I have data published in the major cancer journals. And when everyone else was giving them at least 6 months before, and then during, and then 2 years after, I had recognized that there were a lot of side effects to it. So I tried to pare that down. And in fact, we looked at it over the course of decades and found, no, it wasn't really so necessary to be giving them up front before the radiation, maybe a little while after the radiation, but it was all about during, for the reasons I've told you. Makes sense. If you're using hormones, it's because the radiation's hitting the DNA and it's not allowing it to repair. So why do I need them before I even give the radiation? All I'm doing is subjecting myself to more side effects. So my position is it's all about during. Again, and a little after, because even though radiation course may finish today, it hasn't stopped working. Okay, but not a big fan of during. I'm sorry, before. Big fan of during the actual treatment course.
So would Avodart be considered a hormone therapy or?
So he's asking about another drug that we call Avodart. It's also known as dutasteride. Dutasteride is not a hormone. Okay, we use it a lot around here. And we know it's an effective agent in cancer, but we also know it shrinks the prostate tissue. That's its primary purpose, was for benign prostate hypertrophy, BPH. And Avodart does that. But there's an interesting side note with Avodart, and that is that, again, testosterone, right, feeding prostate cancer, but left to its own accord, testosterone will break down to another molecule called dihydrotestosterone, also known as DHT. Well, Avodart doesn't allow that conversion. So it doesn't allow testosterone to become DHT. And DHT is also pretty powerful stimulating prostate cancer cells. So by shutting that down, it's not a bad idea. What it actually does do is it increases the level of testosterone, because again, it's not breaking down to DHT, so there's more left around. We use it a lot. We typically use it with hormones. We use it without hormones. In fact, often when someone finishes their hormonal regimen, we keep them on that because it really has no major side effects. It's not a hormone, but it does have a way of kind of surveilling your body and taking away this other important metabolite called DHT, which stimulates prostate cancer. Also, a lot of my men are happy about it because it causes hair growth. That was another, thing that Avodart. Its little brother is called Proscar, finasteride, and it is also used for hair growth. And then its even tiny little brother is called Propecia, which is a really small dose of it. And they're all used for hair growth. So, yes, sir.
What is the difference between Avodart Tamsulosin?
So he's asking difference between Avodart and tamsulosin. So tamsulosin, which is also called Flomax, okay, is used for men who have an enlarged prostate, benign prostate hypertrophy. It appears that when a gland is large, it's just bothered. You know, it's a big gland, and what it does do is it causes muscle spasms, okay, because it's just large. And you know, the prostate is primarily striated muscle, and what it ends up doing is interfering with this, again, this all important bladder which sits above it, and just annoying the heck out of the bladder. So what the Flomax and tamsulosin do is they relax the muscles of the prostate, even in the setting of an enlarged prostate. They also have some properties we call alpha blocking in terms of relaxing some of the bladder musculature as well. So the end product is it relaxes the prostate. It's used for benign prostate hypertrophy specifically. Okay, so that most men who, let's just say, having difficulty with all the potential side effects of having an enlarged gland, frequency, urgency, getting up more at night, a weakened stream, they can benefit a lot. I often hear men say, I did that and wow, it was overnight. You know, I was feeling a lot better with this tamsulosin, also called Flomax. In contrast, the Avodart does not relax the prostate muscles. It may ultimately, but what it does, it shrinks the prostate. And again, that was another one of its initial purposes, to shrink the prostate, so that what ends up happening is the prostate reduces, and that smaller size is just the prostate's happier about it, and it doesn't push into the bladder and annoy the bladder. So they both have the similar goal, is to improve urinary symptoms, but you know, one works more directly in terms of the muscles, the other reduces the size of the gland. But if you did have a lot of urinary symptoms, Avodart's not going to work overnight, and it's going to shrink the prostate over the course of months. And the studies suggest that in a year, the prostate itself may be reduced by 40%. That's huge. That's a big size reduction, but it won't work overnight. So a lot of times you'll hear about using both of those drugs for benign prostate hypertrophy for the two reasons. You know, one is relaxing the prostate, the other is shrinking the prostate, and that's just how it works. And hopefully, by the time you've shrunk your prostate in a year, maybe you don't even need the tamsulosin anymore to relax it.
Well, why would you just use the Avodart rather than a vaporization procedure or button therapy?
So he's asking, why not Avodart instead of going through these procedures, you know, the Roto-Rooter or the vaporizations and nucleations? Well, because again, similar to tamsulosin, which works instantly, so do the vaporizations and the nucleations and all those things. They're more immediate, you know, whereas Avodart's going to do it slowly. So for those guys who can deal with their symptoms and just say, well, I'm going to ride it out. You know, I'm going to ride the wave until my gland shrinks and maybe take some tamsulosin or Flomax along with it. Then, you know, over time, I'm going to be peeing a lot better. And guess what? I didn't even need those procedures. And that's a great thing. But, you know, sometimes it's just not, you know, you just want to get rid of those symptoms right away. And, you know, the urologist is going to always say, okay, yeah, let's go. Let's do the vaporization or the TERP. Yes, sir.
Does the Avodart give you a false reading on your PSA?
So he's asking about Avodart and PSA. So I got to tell you, the Avodart does reduce your PSA also, and typically by a half. And it does that faster than a year. You know, typically within 90 to 120 days, your PSA, if it was 10, it's 5. It was 5, it's 2.5. And so it definitely does reduce your PSA, and that's important, because for those guys who are picking numbers like, well, you know, I'm going to concern myself about the prostate when my PSA is 8 or 9 or 10, But if they're on Avodart, well, that same number is when they got their PSA of 4 or 5, because you just double it. And so it is already, if your PSA is 4 or 5 on Avodart, it's really 8 or 10. Okay. Yes, ma'am.
Can I come back to Breaky?
Yeah, come back to Breaky. I love Breaky.
So, question about what would be needed to qualify for Breaky procedure and the temporary versus the permanent implant processes,
So
and the hormonal component.
yeah. So she's asking about brachytherapy, candidacy, and then the types of brachytherapy. And generally speaking, a person is, if he's a candidate for a radical prostatectomy, in all likelihood, is a candidate for prostate brachytherapy. We do have size concerns. So sometimes your prostate's really, really large. And in a really, really large gland, we might not be able to get a perfect implant. Okay, so what we do here is we will try to encourage a man into taking Avodart or maybe even hormones, because hormones shrink the prostate down a lot. Okay, and that's just another way to shrink the gland in a person who has documented prostate cancer. But there is a size constraint, and that's the major one, and I know that some doctors will say, well, if you have a lot of urinary symptoms, you shouldn't have brachytherapy. I have found that not to be the case, and I've published extensively on this. As I said, I wrote the book on brachytherapy, many books, and have demonstrated that if the seed implant is done properly, it's not a problem. So, for example, with prostate brachytherapy, there's different ways of doing it, okay? And one way is called a uniform seed implant. And we're talking now about permanent implants. The ones that you put in, they're tissue compatible, they don't interfere with anything, you don't have to take them out, okay? And what you do is you put them in different arrays. One way that you could put them in is something we call uniform spacing. And what it basically means is that every single seed is uniformly spaced to every other seed. And this was actually first used and continues to be used by some of the doctors or brachytherapists on the West Coast of the United States. Well, I was one of the first to point out an absolute problem with this. Now, the best way for me to explain that is if you just think about it, if each and every one of the seeds that I've showed you is an electric heater, okay? Just say they're electric heater, and you are the guy sitting in the middle, because that's an important structure right there, your urethra, a very important structure. Okay, you kind of want to leave it alone. But if you think about it, you're in the middle, and those electric heaters are really close and far. That dose or that heat that you're getting in the center is really, really hot. And I identified it a while ago that if you picked a point, let's just say here, compared to here, the dose here might be 8 to 16 times higher than the dose out here. Doesn't make a lot of sense because most prostate cancers begin along the edge in the area we call the peripheral zone. They don't commonly begin in the center. Okay, you may want to treat the center to a certain dose because there might be some microscopic cells, but it's unlikely that there's macroscopic cells. So what I did some time ago is I said, okay, how do I lessen the heat to those people sitting right in the middle? Okay, well, as you may understand, if you were to put the seeds like that in what we call peripheral seed loading pattern, well, you're still surrounded by those electric heaters. The dose to the center probably more than adequate to get a dose. You'd be hot sitting there, not as hot if you had them right next to you and all the way around you. So that's called peripheral loading, and it makes more sense to me because that's where most tumors begin also, the periphery. So that's the difference between uniform and peripheral loading. The second question is permanent versus temporary implants. And I've done thousands of temporary implants. I don't like them. When I first got involved with temporary implants, in that case, what you're doing is you're leaving needles in for a short period of time, like this, and you put them in, and then you have a machine that threads the radiation to those needles, and then or after 10 or 15 minutes takes them back out. It's called high dose rate brachytherapy. Well, when I first looked at it and tried to make sense of it, I found that to get a comparable dose, you had to do that 5 or 6 times. And guys are just not going to come back 5 or 6 times and have needles put in them. So what's happened, and it's unfortunate, is that most places will do it like 1 or 2 times because I know that's all the guys will do. In the process, though, they got to give more scathing doses to the prostate. Also, it's high dose rate, and the material that you use is called iridium-192. Very, very penetrating isotope. When you use other types of permanent isotopes, you put them in different areas. They don't work out here. They don't work anywhere but where you're putting them. And meanwhile, with the high dose rate temporary brachytherapy, the dose is really high. And here in radiation oncology, our overwhelming objective is how do you deliver high doses to tumors and low doses to surrounding areas? Well, you could do that with permanent prostate brachytherapy. With the temporary, the doses to surrounding areas, your rectum, your bladder, is really high. It's a very penetrating isotope that's used for temporary implants. In fact, when I used to do it, and during those periods of time when I was doing it 5 or 6 times, I would have the guys stare at their groins and put lead shielded goggles on them so that they wouldn't develop cataracts. So anyhow, that's pretty much the reasons why I do what I do. Time is up, folks, but I appreciate your coming and coming with your questions. All right.
Saw your Tuesday.